Good afternoon, everybody, and welcome to Cure PSP's Ask the Doctor, session number 10. Thanks to you all for tuning in today via YouTube and Facebook Live. Amazingly, we are approaching our year anniversary of our Ask the Doctor series. Hard to believe, but we hope that you are all continuing to stay safe and healthy. My name is Joanna Teeters, and I am the Community Outreach and Resource Manager with Cure PSP, and I will also be the moderator of today's Ask the Doctor webinar. Please note that this is a recorded webinar, and the recording will be made available on our website in the next few days. The link will be provided in a follow-up email. And a quick overview for the platforms that we are using today, Facebook Live and YouTube. Please type your questions in the chat box or the comments section of the platform you're using, and feel free to use the chat boxes to interact with one another. But please do not reveal personal medical information. Also, please note that any medications mentioned or referred to in this video should not be tried unless under the supervision of a medical professional. The questions that Dr. Golbe will answer today were submitted prior to this webinar, and if you submitted a question that was not answered here today, it's likely that the question was already answered in a previous Ask the Doctor session, and I do implore you to go to our YouTube channel, Cure PSP TV, and take a look at the other Ask the Doctor webinars, which are chock full of other important information. And today we have with us Dr. Lawrence Golbe, Emeritus Professor of Neurology at Rutgers University, Robert Wood Johnson Medical School in New Brunswick, New Jersey. He graduated from Brown University and New York University School of Medicine and did residency training at NYU Bellevue before joining Rutgers in 1983. He was acting chair of his department from 2000 to 2003 and was program director of the neurology residency from 2003 to 2018. His research is in the clinical genetics, clinometrics, and epidemiology of the Parkinsonian disorders. In 1988, he co-led the first studies of the prevalence and risk factors in PSP. He led the clinical portion of the project that in 1997 identified the first known Mendelian mutation causing Parkinson's disease in the gene for alpha-synuclein. He devised the PSP rating scale, which since its publication in 2007 has become the standard clinical measure and treatment outcome marker for PSP worldwide. His current research centers on a geographical cluster of PSP. He has worked closely with Cure PSP since 1992, presently as the Director of Clinical Affairs, Chair of its Medical Advisory Board, and a member of its Board of Directors. And at this time, I would like to welcome Dr. Golbe to today's program. Thank you so much, Dr. Golbe, for being here with us today.
Thank you, Joanna. Thank you for the kind introduction, and thank you all for tuning in. I know it's a very daunting, difficult task to sort of digest all the information that's available on this disease. It's a very complicated disease, and it's a rare disease, so it's hard to find experts. And thank goodness for the internet, which allows us to broadcast information much more easily than was available when I started out in this business. So there are a lot of questions that have been submitted, and I don't want to delay any further, so I'm just going to get right into it. I'll read the questions first. There are a lot of questions, of course, on what's new in a cure, when and what and how and what form might it take. I've prepared a little list of the medications that are going to be entering clinical trials. Right now, there are no medications in clinical trials for PSP. There would have been if not for the pandemic, but clinical research, clinical trials pretty much ground to a halt because of the pandemic. So I'm going to hit share screen. And let's see if this works. I hope you can see my screen. If not, at the bottom is a list of 7 kinds of medication. I'll read them off in case you can't see my screen. List of 7 kinds of medication that are going to enter clinical trials either as soon as the pandemic lifts or within the next year and a half or so. The first one, RT001, addresses the problems with lipid peroxidation. I won't explain what all this biochemistry means, but that's an oral medication. There's an anti-tau antibody. As you see from the lines above it, there have been 2 anti-tau antibodies that have failed in the past couple of years. This one is different from those 2. Those 2 were alike in an important way. This one is different, and so there's hope for this one. Although the company that is sponsoring it has announced an indefinite hold on that, so it's not going to be in the next year or so. They're testing it on Alzheimer's in the meantime. Then there's this drug. This is an oral drug, this ASN 120290, which addresses a chemical problem on the tau molecule. By the way, in case you're new to PSPology, tau is the protein that accumulates in an abnormal way in the brain cells in PSP. It forms these tangles. It's a normal protein that we all have. It's just that it misfolds on itself and forms these tangles if you have PSP. And we don't know the exact role that the tau has in the production of the disease. We just know that it's there. Then the next one, the 4th one, is ezeprogend, which induces the formation of proteins that help the brain cells repair themselves. And the next one is called MP201. It's a mitochondrial uncoupler. That means that it helps the mitochondria, which are damaged in PSP. The mitochondria are the little factories in the cells that make energy, and that's one of the main problems in PSP. Those aren't working well, so this will help that problem. Then there's one called tolfenamic acid, which is actually a non-steroidal anti-inflammatory medication, which is on the market in Europe. But it has a unique property that other NSAIDs don't have, which is that it affects the production of the tau protein. And finally, there's at least one, probably 2 drugs called antisense oligonucleotides. Sorry about the long words here, but what they do is directly reduce the ability of the DNA to translate their instructions into tau protein. And since these are large molecules, they have to be injected directly into the spinal fluid at the base of the spine in a procedure that's exactly like a spinal tap, except instead of removing fluid, the doctor injects something. So that is that's a rundown. And now I will figure out how to unshare. And we will go to the questions, the other questions. Okay, is there information about postencephalitic PSP? Well, this is kind of a appropriate question for the times, because back in about the time of the flu pandemic, in the early 1920s, there was this disease that happened at about the same time as the pandemic, a little bit later, called encephalitis lethargica. We don't know what the cause was exactly. It was, we assume, a virus, and it was called encephalitis lethargica because it made people sleep very profoundly for days or weeks. And when they woke up, some of them developed this Parkinsonian disorder. And when you look at the brain under the microscope, that looks a lot like PSP. It's not the same disease, but it looks a lot like it with tau tangles. So naturally, there's some suspicion that maybe PSP is a delayed result of some kind of encephalitis, of viral encephalitis. That hypothesis has been tested by researchers, and it does not look like it's true. And we certainly don't see people waking up from other types of encephalitis with PSP. So the answer is that it's probably, the PSP is probably not a postencephalitic disease. A related question, how are PSP patients responding to the COVID vaccination? Well, actually, Cure PSP has a little facility on its website for people to enter information about adverse reactions to any of the COVID vaccines. And as of this morning, there was no particular excessive reporting of side effects from COVID vaccines in PSP patients. Of course, it's not a formal population survey. It relies on people taking the initiative to report. But you'd expect that if people had a lot of adverse effects, they would be more likely to over-report than under-report. And so it looks like PSP does not present any kind of issue against getting vaccinated. Okay, next question. What's the difference between MSA-C and PSP? MSA-C, multiple system atrophy of the cerebellar type. This is one of the common forms of multiple system atrophy, which is a brain disease similar to PSP in some ways, but a little less common. The difference is that MSA-C doesn't have as much eye movement problems, and it doesn't have as much cognitive problems as PSP, and it does have more autonomic problems. That means low blood pressure, bladder, bowel problems compared to PSP. And of course, the C, cerebellar, is an issue that's very prominent in MSA-C, and in PSP, it's only a minor issue in the vast majority of patients. The cerebellum, of course, is the part of the brain in the back that helps control coordination. Next question. My wife has had PSP for about 11 years, which is longer than most people survive with PSP. The past 2 years, and so when you hear that someone's had PSP for 11 years, a neurologist thinks, well, maybe this is the kind of PSP called PSP Parkinsonism, PSPP, because that's a type of PSP that has a longer survival, and it has less of the things that classic PSP has, such as a lot of falls. In the past 2 years, she's had a series of seizures and is on medication for the issue. Are you seeing many PSP patients with this condition, with seizures, in the later stages? The answer is no, not a lot. Parkinson's disease probably has fewer seizures than other people of the same age, and PSP has more than Parkinson's, but it may not be any more than the general population. Bottom line, if you have PSP and then you develop seizures, regardless of what stage of the disease, you should see a neurologist about the seizures just the same as you would if you did not have PSP. Because seizures can be the first sign of some really serious brain problems, and seizures, of course, are preventable with medication. And maybe the brain problem underlying the seizure can be cured. Do we understand what causes or triggers PSP? The short answer is no, but in general, I can say that there is some kind of a pre-existing vulnerability, whether it might be genetic, it might be caused by who knows what, just bad luck, and then there's something that precipitates it, most likely, maybe an exposure, maybe a very low-level, multi-decade exposure to some kind of chemical. And we don't have a great idea of what that chemical might be. The only the only epidemiological risk factors that have been identified for PSP are well water use, and even that is not rock solid. Well water has more chemicals in it than reservoir water. And less education. People with less education are a little more likely to get PSP, and we don't quite understand the reason for that. And we do know that there are some genetic mutations that slightly increase the risk of getting PSP, but we don't have tests for those yet. Next question, does CBD cause bowel problems, corticobasal degeneration? I assume that's what the questioner is talking about, as opposed to cannabidiol. Does CBD, now CBD is very closely related to PSP. It's less common. It can cause a wider variety of different things, but both diseases can cause bowel problems. All of these Parkinsonian disorders, including Parkinson's itself, have constipation as a very frequent symptom. Fortunately, it's easy to treat in most cases if you pay attention to it and if you try different treatments under a doctor's supervision. How do we know what stage of PSP my husband is in, since this disease affects everyone differently? It certainly does affect everyone differently, and that's why there are no hard and fast stages, because it affects everyone differently. So trying to create a set of stages will only apply to a certain fraction of people with PSP. Nevertheless, I have attempted to create a couple of different staging systems, actually 3 different staging systems, none of which is published, but they all have their uses. So if you want to know, somebody who asks what stage is this person in, really what they're asking is how long does the person have left to live in a non-disabled state, or how long do they have left to live, period. And that's a really complicated question. That can only be answered by a doctor who's very familiar with the patient. How inheritable is PSP, and should the adult children undergo screening or look out for signs of the disease? I think I've answered this question at each of the Ask the Doctor sessions, but it's worth repeating because it's a very common question. It is very, very little inherited. There's almost no increased risk of the children or other relatives of people with PSP. Yes, there are a few families where a parent and child or 2 siblings both have the disease. They're very rare. They may be coincidence. So as you'd imagine, if you have a parent with PSP or a sibling, there's nothing you need to do, nothing you should do different in terms of planning for the future. And should you look out for signs of the disease? Well, if we had a way of preventing the disease starting from an early stage, then I would say yes, but we don't have that yet. When we do, I will certainly let you know. How to care for a patient in the end stages? Well, that is, there's a lot of things that happen in PSP in the end stages, and all these things have their own way of approaching them. There's the bladder problems, the bowel problems, behavioral, cognitive problems, the speech, the swallowing, the general movement. All these things can be treated to a greater or lesser degree. And a lot of doctors know about these things because these are the same, the treatments would be the same as if these symptoms were part of any other chronic illness, even non-neurological illnesses, like somebody with bad arthritis has many of the same challenges that somebody with advanced PSP does. But just to disseminate that knowledge a little further, Cure PSP has organized a group of experts called the Cure PSP Centers of Care. These are the directors of the centers. They're all over the US and a couple in Canada, who have put together an article, a scientific article that's going to be published in the next few months that will describe the treatment of all these things that hopefully general neurologists or primary care physicians can access. It'll be in a journal that's open access. If the person's unable to communicate, how can you tell if they're in pain? Well, very often people with PSP can signal yes or no by putting up one finger, two fingers, or some other kind of hand signal that you can train them to do. Even if you can't do that, facial expression, groaning may communicate pain. Now, people with PSP tend to groan. That's a very common symptom, and it doesn't necessarily mean they're in pain. And I should also tell you that usually pain is not part of PSP in the majority of cases. So don't rush for the morphine. Let's move along here. Any exercises for vision? I cannot move my eyes up or down. Well, of course, the difficulty moving eyes up and down that's the hallmark symptom of PSP. That's what the disease was named after. The supranuclear palsy refers to weakness in moving the eyes up and down. And there are exercises for that. They haven't really been tested in a careful fashion like a drug would be tested, but I would suggest that you consult there's a specialty called neurooptometry. These are optometrists who have a specialty in neurological disorders, and they can prescribe exercises. Sometimes physical therapists know how to do this. And there are ways of getting around the problem. For example, if you have PSP and the problem isn't too far advanced, it's a lot easier to follow a moving target than to move the eyes of your own accord. So if the person is staring straight ahead and they want to look down at their dinner plate, what you do is you tell them to put the fork up here and then lower the fork slowly down to the plate, and that will allow their eyes to go down. All sorts of tricks like that. Of course, you could also raise the plate on a box or something. I'd like to learn the main differences and similarities between PSP and Parkinson's disease. And this person goes into all kinds of detail about this relative's history of diagnostic difficulty between PSP and Parkinson's. Well, the main difference between PSP and Parkinson's, there's lots of differences. The main one is that in PSP, there's a lot more, in most people, there's more falling early in the course. Of course, there is a form of PSP, that's PSPP, which I mentioned before, which does not have much falling early in the course. Another difference is that tremor is more common in Parkinson's. And a big difference is that response to medication is more robust and longer lasting in Parkinson's. There's more dementia in PSP, and the dementia looks a little different. Which brings us to the next question. In the advanced stages, how much is cognition affected by PSP? Okay, well, first of all, let me explain what the difference is between cognition and behavior, because it's two different things. Cognition is things like memory and ability to understand and produce language, ability to plan, to process information in your brain, decide what's important, what's not important, come up with new ideas. That's cognition. Behavior is things like your mood, your inhibitions, your whether you care about things, or whether you're apathetic. Those are all things that are a problem in PSP, actually. Okay, so the question is, how much is cognition affected? Pretty much everybody with PSP has some problem with cognition sooner or later. And the main problems with cognition in PSP are trouble organizing the thoughts, trouble coming up with new ideas, trouble assigning priorities to things, trouble making a plan, multitasking, and this is pretty important, although this is behavioral, is inhibiting instinctual impulses. And it's a major issue for a lot of people with PSP, but there are medications that can help in some cases, and it's worth exploring these with a neurologist. How much does PSP interfere with eyelid movement? It can interfere quite a bit. The main eyelid movement problem in PSP is reduced blink rate. And because you don't blink as much, the surface of the eyes can dry out, and that can produce pain, and can produce light sensitivity and a little inflammation, and it can also produce excessive tearing. Now you'd think, well, if there's excessive tearing, then doesn't that prevent the eyes from drying out? Well, no, because in the eyelids there are these glands that produce oils, and the oils, as well as tears, are necessary to keep the surface of the eye adequately lubricated. And in response to drying, you don't increase your production of oil, you just increase your production of tears. And so that's not enough. So the eyes still can dry out. Still, using the right kind of eye drops can help. And this is another area where a neurooptometrist can really be a good kind of doctor to consult. Please address ocular motor issues affected by PSP. Well, I've already mentioned that looking up and down are the main problems, but also there tends to be, you can have the problem different in the two eyes, which means that the two eyes aren't looking at exactly the same spot, and this produces double vision. Another cause of double vision in PSP is just that the eyes are so slow in getting to the target of interest that it gives the feeling of double vision. Another reason double vision can be reported is that in PSP, the eyes can have these things called square wave jerks, which is where the two eyes, instead of looking right at the object of interest, they make these little flicking movements to one side or the other, kind of random right, random left, and they come immediately back to the initial point. But these can occur very frequently, and they have the effect of messing up your focus, and it gives you multiple images. So that's another explanation for why, quote, double vision is so frequently reported by people with PSP. We don't have a treatment for the square wave jerks. Are neck pains common and related to the disease itself, or is it due to being tired and stressed? Neck pain is common. It's not usually a severe pain. It can usually be relieved by some Tylenol or Advil, or a massage, or a heating pad. And it is related to the disease itself because there's a lot of just inability to move the muscles of the neck. So if you just, even if a healthy person just sits there without moving their neck for a long time, it's going to start to ache. And in addition, in PSP, those muscles just get stiff, they get hard. And so that will cause them some pain. There have been some attempts to treat this with various pain management strategies, and it might be worth consulting a pain management specialist for this. Also, sometimes if the neck is in an abnormal posture, and it's called cervical dystonia, where the neck is held in an abnormal posture, like like this, that may respond to injections of Botox into the neck muscles, but that has to be done really, really carefully in someone with PSP, because the Botox can leak from the neck muscles into the muscles of swallowing. And if you're already having trouble swallowing and those muscles get weaker, then you can really choke on food, and that would be very dangerous. So that has to be done really carefully. Next question. My husband repeatedly rubs his nose or scratches his head for hours at a time. Is obsessive compulsive disorder common in PSP? No, OCD is not common in PSP. When somebody who has a Parkinsonian disorder repeatedly does these actions, you have to think that maybe it's a side effect of some medication they're on. The dopaminergic medications, especially the dopamine receptor agonists. Sorry about the technical terms. Drugs like pramipexole and rotigotine. These drugs can cause, and to a lesser degree, levodopa. These drugs can cause compulsive behaviors, not just scratching or rubbing, but shopping or eating or rearranging the knickknacks or rearranging the furniture or gambling. And the gambling can be a real problem. I mean, people have gone broke. People have lost their houses because of these medications causing compulsive gambling. And very often the doctor hasn't heard of this, doesn't make the connection. The family doesn't make the connection. So that's why in my own patients, any patients who I have on any of these drugs, every visit, as a routine, I will ask any excessive gambling, any compulsive behavior. And of course, I have to ask the caregiver. I can't rely on the patient's report. So the solution is to try to reduce those culprit medications. Could medications be responsible for frequent falling? Oh, yes. There's a medication called amitriptyline. The brand name is Elavil. And this medication, many years ago, back in the 1980s, I think, had a trial. A paper appeared in a good journal that reported that it helped PSP, very small number of patients. And so this was the cat's meow for PSP. And when I started working on PSP, this was standard treatment. And I found that it was making my patients fall a lot. And now this is now the standard wisdom. And so, but nevertheless, a lot of doctors haven't gotten that word, and they're still giving it for PSP. And so people who are on amitriptyline and are falling a lot should have their amitriptyline replaced by something else or just discontinued. Also, drugs that cause sedation, like the benzos, the benzodiazepines, these sedative and muscle relaxing drugs, they can certainly cause falling. Baclofen is a muscle relaxant that sometimes is prescribed for the muscle stiffness of PSP. That can cause weakness in the leg muscles, or in all the muscles, but weakness in the leg muscles can cause you to fall. So that could be causing falling. Okay, next question. My husband has stiffening episodes where he becomes like a statue and then huffs and puffs like a locomotive. I understand that this is not a common occurrence, correct? But yet not uncommon. Well, it is uncommon. In general, when anybody has these stiffening episodes, you have to consider the possibility that these are seizures and consult a neurologist. And very often seizures are followed by excessive breathing. But there's also this type of breathing called Cheyne-Stokes respirations, where the person stops breathing, and then gradually starts to breathe deeper and deeper until they look very short of breath, and then they gradually, over the next minute or two, goes back down to not breathing. Maybe that's what's being described here, and that can be a symptom of different things: congestive heart failure, blood problems, circulatory problems, problems with the viscosity of the blood. So that requires a workup by a doctor. Okay. My husband is constantly trying to clear his throat. He seems to have excess phlegm. This is a very common problem in PSP because there are some medications that produce excess phlegm, and in PSP, dehydration is common. So your phlegm will get thicker and drier. Why is dehydration common in PSP? Because it's tough to swallow water without coughing, and so people just avoid drinking water. Also, because in PSP causes problems with the bladder, people will voluntarily drink less water in order to have to pee less frequently. So if there's anything that can help, the thing that can help the most is hydration, is adequate hydration. But there are some things that can clear phlegm, that can dry up phlegm, and that's a conversation with the doctor that you have to have. My wife leans far to the right and forward when sitting. Is this common with PSP? Yes, this is very common, where a person's leaning way to the side and sometimes forward as well. It's also common in Parkinson's disease and in all of the Parkinsonian disorders. And it would be treated the same way as you would treat any other aspect of the slow and stiff movement in those diseases. And physical therapists or occupational therapists can really help here because they may prescribe a wheelchair that has a structure that prevents the leaning over too far. You don't want to use a harness, any kind of brace. Those things are just very uncomfortable for the patient. Also, providing the patient with just a type of a chair that has sides to it, and putting pillows between the shoulders and the sides of the chair that's by far the most common solution, and that works just fine. Could you give us some guidance about when and why it's beneficial to have hospice become involved with a PSP patient? Hospice, very common issue. The purpose of hospice is to make patients comfortable in their final days, weeks, and months. It's paid for by Medicare. The catch is that Medicare won't pay for specific treatments for the disease. And with people with PSP, the thinking now is to move to a hospice arrangement sooner than was previously thought. For one thing, hospice used to require that the doctor certify that the patient is likely to have less than 6 months to live in order to engage the hospice benefits. And now that's no longer a requirement. The doctor may have to recertify after 6 months. So for a person in hospice, there'll be somebody who comes around to the home, a nurse, somebody trained who will check up on the person. There'll be a supply of emergency medications that's left with the caregiver, including pain medication. And it's really, I mean, the patients and families, or certainly the caregivers, are very grateful to have hospice. It's a wonderful program. So, and of course, you can go off hospice. You know, it's not irreversible if the underlying problem improves, or if there's some other reason that you don't like it. So I'm a proponent of that in the proper situation. PSP is a rare disease, but has there been an increase in the number of PSP diagnoses recently? There's no real evidence that it's increasing. There is one spot in Japan where it may have increased a lot over the past 20 years. Excuse me. I'm not really convinced that those two surveys were accurate. However, we understand now that PSP has all these different types of appearances that we didn't initially understand back in the 1980s when I first did the first survey of the prevalence of PSP. We now know that PSP can start in a lot of different ways, and so now we think that it's about twice as common as we thought then. It doesn't mean that the disease actually is more common. It just means that we have a better understanding of it. And so rather than 6 patients per 100,000, now it's probably twice that. How do you prevent urinary tract infections in PSP or CBD? The way to do that is to maintain hydration. Make sure you always got plenty of fluid. Keep your water bottle handy, everybody. And when the bladder is full, you go pee. You don't try to hold it in. Now, I know that with PSP, it can be hard to get to the bathroom. You may need to wait for help. It may be a fall risk. It may be, if you got a wheelchair, it's hard to get the wheelchair into the bathroom. I know all those things, but you can't let the urine sit in the bladder too long, because bacteria will start to grow. The bacteria, normally the inside of the bladder and the urine are sterile, but the external end of the urethra is not. And the bacteria will just work their way up the urethra until they get into the bladder, and then they will infect the bladder. And what prevents that normally is frequent washing out of the urethra. It washes out the bacteria before they can gain a foothold in the bladder. And if you're not doing that, then you're going to get an infection. Okay, where are we here? Is the loss of smell a symptom of PSP? Here's another topic where I helped write the first paper on this topic way back. Loss of smell, first of all, in Parkinson's disease and Alzheimer's disease, loss of smell is a big issue, very common. In PSP, it's about half as bad as that. Different studies have shown different results, but generally it's about half as frequent and half as severe as in Parkinson's. There seems to be a wide variation on the length of time someone may live with PSP. Yes, these different variants, like the PSP Parkinsonism, and there's a half a dozen others, they all tend to have a longer survival than people with the classic kind, which is called PSP Richardson syndrome. And what explains this? Well, we certainly don't know, but the theory is that it's there might be some kind of genetic, the risk genes may have a different combination of risk genes in these different kinds of PSP, which produces a different type of misfolding of the tau, a different pattern of the misfolding, and that may affect the ability of the tau to damage brain cells in a different way. So the different types of tau may have a predilection for a different set of brain cells in a different part of the brain, and of course that'll produce a different set of symptoms. Okay, they say that falling over backwards is one of the first signs of PSP, but they're talking about a person who has had symptoms for 6 years, and while there is speech, swallowing, and eye movement issues, there's still no falling. Well, this most likely well, either there's a complete misdiagnosis or it's PSP Parkinsonism, or one of the less common varieties other than the classic PSP Richardson. Do patients with PSP ever have delusions or hallucinations like Parkinson's patients? Basically, no, they do not, unless they're on medication that produces the delusions and hallucinations. And the most common such medication is levodopa. And most patients with PSP do get a trial of levodopa. And so that could be it. Or they could get trials of other Parkinson medications, or trials of a group of medications called anticholinergics. Those can all cause delusions and hallucinations. So if someone with PSP has those symptoms, the doctor should try to slowly cut back on those medications. And I say the doctor should. Do not undertake this on your own, please, without the doctor's supervision, because that can cause big problems. What is the maximum dose of PSP? What is the maximum dose of Sinemet for PSP? And what do you do once you reach the max? Okay, Sinemet, for those of you who don't know, is the trade name, the brand name, for the combination of levodopa and carbidopa, which is the way that levodopa is given, is along with carbidopa, which prevents a lot of the side effects that would occur from plain levodopa. So the maximum dose is about 1,200 milligrams of levodopa. So it typically comes in tablets that have 25 of carbidopa and 100 of levodopa. So that's 12 of those tablets per day. And it's the maximum dose, not because higher doses are dangerous. It's because if you don't benefit from that dose, you're very unlikely to benefit from higher doses. And what else do you do once the maximum dose is reached? Well, first of all, if you reach the maximum dose and it's not helping, the doses under a doctor's supervision should be cut back until it's discontinued, or until the symptoms worsen, at which point the dosage can be stabilized at that point. And what else can be used? Well, it depends what symptoms you're trying to treat. Now, the main thing that should be treated by levodopa is the slowness and the stiffness and the tremor, if there is any, which is only a minority. It's not going to help the swallowing, the speech very much. It certainly isn't going to help the balance problem or the cognitive problem or the bladder problem. If those are the main issues going on and there's not a lot of slowness and stiffness, then maybe you shouldn't have been on levodopa in the first place. As for what else can be used, something I try in all my patients, especially those who have balance problems, all my patients with PSP or CBD, is coenzyme Q10 in the liposomal form. I've discussed this at previous Ask the Doctor sessions. This is a natural compound that helps brain cells make energy, and it's not working well in PSP. And so a supplement can help. There actually has been a double-blind trial showing that this is the case. Modest benefit, but some people benefit more than modestly. And after 2 months, if it's not helping, then it should be discontinued, again, with a doctor's advice and consent. It's a liquid, and it's taken as with a medicine dropper that comes in the vial. And it's available over the counter. You can order it online. I've never seen the liposomal form in drugstores. Next question. Oh, and by the way, with levodopa, if you reach the maximum and after a couple of months, if it's not helping, you shouldn't just you shouldn't just stay on it and hope that, well, maybe in a few more months it's going to help. It's not. And of course, it can cause side effects as time goes by, including hallucinations. So that should be discontinued with a doctor's help. Let's see. Does CBD cause bowel problems? Corticobasal degeneration? Yes. Oh, wait a minute. I'm repeating this. have some questions here that are repeated. Okay. My wife has PSP and she experiences some leg freezing. What he means is gait freezing. The rest of her body wants to move, but not her legs. It takes a few seconds for her to move her legs. Is this normal in a PSP patient? This is very common in PSP. It's called gait freezing. In fact, one of these new types of PSP that's been described in recent years features this. This is the most important symptom of that type of PSP. And there's a medication called amantadine, which is an old Parkinson medication, came out in the 1960s, which can help this symptom. Is levitation of a leg common? What about raising an arm and pointing? I know it sounds weird, but the answer is yes. This is more common in corticobasal degeneration than in PSP, much, much more common. It can still happen sometimes in PSP. This is usually in the setting of apraxia. In other words, it's usually in people who already have apraxia as one of their symptoms. And what is apraxia? It is a loss of a skilled movement ability. So for example, you can have apraxia for writing. You can have apraxia for use of tools. You can have apraxia for any kind of skilled movement of the hands, or all skilled movement of the hands. You can also have apraxia for speech, and you can have apraxia for gait. And so that can, and that's called gait freezing. And as I say, it can respond to amantadine. Now, there are other causes of apraxia of gait besides PSP and CBD, and that's something, I'm not going to get into that right now, but it's something that a neurologist should work up. And when there's levitation, usually it's about levitating an arm. It's called the arm levitation sign. Where a person just sitting there doing nothing, and the arm starts to float up like this. There's no medication for that. It might be helped by some kind of occupational therapy. What are the similarities in early stages of PSP to early stages of MSA? And I think I'll make this the last question and give Joanna a chance to relay any questions that have been submitted while I've been speaking. What are the similarities in the early stages of PSP, the early stages of MSA? There are a lot of similarities. The two diseases can be indistinguishable in the early stages, especially the classic kind of PSP or the Parkinsonian kind of PSP. In fact, the two are so similar that there was a drug trial that was performed in Great Britain about 10 years ago. The drug didn't help, unfortunately, but those guys combined patients with the two diseases because they wanted people as early in the disease process as possible. They didn't want to wait a year or two until it would be possible to distinguish the two diseases from each other. And so they just combine them into the treatment group. And even though the two diseases are quite different at the molecular basis, if you look at the brain cells through a microscope. And so how do they both present? They both present with slowness and stiffness, which is the Parkinsonian part, and with a lot of balance problems. And they both can have trouble with slurred speech and swallowing and eye movement, although those are milder in MSA than in PSP. And they may not occur until the middle stages of the disease. Okay, so we have a few minutes left. And Joanna, is there any questions that come in?
We've had a lot of great questions come in. The one that I wanted to circle back on in my introduction at the very beginning of our webinar today, I mentioned your current work on studying the geographical clusters. And there were a couple of questions that came in the chat boxes about whether or not any research has been published on geographical clusters of PSP.
Right. There's been very little. First of all, it's cluster. There's only one cluster that we know of for sure. And I've published one paper describing the cluster, describing the patients, just the statistics of the cluster. That was back in 2015. And then a second paper, I worked with some laboratory scientists to look at the possibility that metals, that industrial metals, which is what's the suspect culprit in that cluster, whether they can actually cause PSP-like changes in brain cells growing in a dish, and it turns out they can. So that's the sum total of the literature on this. This cluster is in a town in northern France, where for most of the 20th century, there was a lot of metals processing of raw ore that was barged in on a canal. And the spent ore, after all the metal was extracted, not all the metal, but after as much metal as could be extracted economically was extracted, they dumped the waste material in a dump that was right near a residential section of the town. And so we haven't proven cause and effect, but we do know that the frequency of PSP in that town is about 13 times what it is anywhere else that we know of.
Very interesting. And if any other information gets published, of course, you'll be able to find it or find mention of it on the Cure PSP website. I think that's all the time we have for the questions today. So thank you so much, Dr. Golbe, for taking the time to be with us here to share your expertise and answer questions from our community. And thanks to all of you for watching and interacting and submitting questions. We did our best to get to as many questions as we could. And if you submitted something that was not answered today, please be sure to review the other Ask the Doctor recordings on our Cure PSP TV YouTube channel. We will also be making transcripts available soon. We are so thankful to all of you for helping to make this Ask the Doctor series a success. And over the past year, we've had the pleasure of hosting some of the sharpest and most cutting-edge neurologists in this important field. So please head over to our channel if you'd like to view those sessions from medical professionals from our centers of care and others. I would also like to make a point to mention that the next Cure PSP Family Conference, which will be a 2-day conference this year, will be held virtually on May 21st and May 22nd. So please sign up. Registration is now live on our website. And this spring's conference will feature many sessions, including topics that Dr. Golbe mentioned today, like neuro-ophthalmology, occupational therapy, emotional support and self-care, and we'll even feature a patient panel. Lastly, these webinars and events are only available because of donations from viewers like you. So thank you all who have generously donated to our organization. We appreciate you being here with us today. We hope that you remain safe and healthy. And please email info@CurePSP if you have any follow-up questions to today's webinar. Thanks, Dr. Golbe, and we'll see you again soon.
Thank you, Joanna.
Take care, everybody.